Today we're going to talk about sustaining both the amount and intensity of practice is necessary to maintain outcomes during post-stroke rehabilitation. We know that nearly 80% of individuals with subacute stroke are going to have some kind of deficit in their walking. We also know that recovery of independent walking is a key predictor as to whether individuals go home following inpatient rehabilitation or to another level of care. Separately, from controlled efficacy trials or randomized trials of high-intensity training, not only focused on maximizing the amount and intensity of cardiovascular training, but also targeting variable training environments, so not only on the treadmill, but also getting them overground, getting them into stairs, getting them into other kinds of simulated community environments, while also targeting their specific biomechanical deficits, right? So stance, postural stability, propulsion, and limb advancement. This combined intervention has been shown to result in greater gains in walking function when compared to alternative strategies, following a variety of acute onset neurologic injuries, including subacute stroke. It's been shown to be superior to conventional therapy, low-intensity walking, and high-intensity impairment-based training. Furthermore, effectiveness studies where there's been a concerted effort to implement this training paradigm into routine inpatient practice have indicated that it's both feasible and safe, and it can result in greater walking and non-walking outcomes. That brings us to the first Indiana project. The first Indiana project occurred at the Rehabilitation Hospital of Indiana, located just outside of Indianapolis. It's a 64-bed acute inpatient rehab facility admitting more than 300 individuals post-stroke per year. The purpose of this implementation project was to take the usual care distributed practice that we see here on the left, where walking is a big piece of the pie, but there's also a lot of other stuff that we spend our time doing as therapists, and really trying to transition it to maximizing the amount of walking practice while minimizing all the other stuff. All while trying to maximize the higher heart rates and the other aspects I talked about, training in different environments, targeting the individual's biomechanical deficits. In order to perform this project, we started first with implementing standardized outcome measures with a group of existing clinicians. We also wanted to make sure that the clinicians were familiar with how to use the equipment they might ultimately need to use to deliver the high-intensity training, so heart rate monitors, different kinds of walking equipment. However, we explicitly did not provide any guidance on how to use this equipment within their clinical practice, just to make sure they knew how to use it. During a 9-month usual care phase, all of the eligible individuals post-stroke wore a stepwatch, which you can see here on the left, which is a research-grade pedometer throughout their therapy day. And we observed a number of therapy sessions to make sure that the conventional therapy that was going on at the Rehab Hospital of Indiana was similar to what's previously been reported in the literature. During a transition phase, we worked to implement the high-intensity training program. We provided 9 hours of in-person training and 8 recorded lectures. We worked on training the therapy aides, helping them understand what kinds of equipment they may need to get to be supportive of the clinician delivering the intervention. So labeling kind of the stock AFOs so that they knew which ones to grab, helping them understand the differences between different kinds of harnesses, those sorts of things, donning a heart monitor, getting blood pressure, that sort of stuff to help the therapist ultimately deliver the intervention. And then also helping make sure that they understood the physical tasks that they may be helping with actually during the intervention. So weight shifting, advancing a leg, whatever the supervising therapist might direct them to do. We worked with the administration team to deliver an order set so that the physicians could be clear about which individuals were appropriate for high intensity training. And we did direct mentoring and co-treating with the treating clinicians and their relevant patients to help with translating this paradigm into their practice. We additionally provided audit and feedback during this phase. So on the left, you can see stepping feedback for a single patient. So the blue bars represent an individual day of rehabilitation and the total number of steps they got throughout that day. The dashed and solid lines represent benchmark data based on individuals with previous levels or similar levels of physical assistance during walking or Berg scores based on the earlier feasibility project. We also provided therapist level feedback on the right. This particular case is an example of a documentation audit for whether or not walking was practiced at all during their therapy session. You can see the different therapists labeled in the rows and level of physical assistance in the various columns. Within each bin for a physical therapist, you see 4 different rows. That's going to be the 4 most recent quarters of the year, so that a therapist can see how their practice may be evolving. While the information is de-identified here, in the actual team meetings where it was provided, each therapist knew how they were performing relative to their peers. We also tracked our fidelity metrics throughout this phase. We were specifically interested in increasing the number of sessions where walking practice was prioritized. So thinking back to that pie chart, really focused on walking, acknowledging there are certain things that have to happen during therapy: toileting, family training, pain medications, orthotics consults, those sorts of things. But the idea of really being amongst the different things we can choose to do as a therapist, were we choosing walking as opposed to strengthening or transfers or balance or any of these other things that are typically done during inpatient rehab for these individuals. So individual sessions were scored as yes or no, as prioritizing walking. And you can see the black dot represents usual care, and then the blue represents quarters during this transition phase. Somewhat similarly, we also were interested in whether or not cardiovascular intensity was documented. Given the level of impairment of the patients seen at this facility, it wasn't clear how feasible it would be to actually achieve the higher cardiovascular intensities. So we really focused on just intensity documentation with the implication that they were subsequently attempting to achieve higher intensities. And intensities, especially because we have a lot of beta blockers at our facility, were considered either heart rates or RPE documentation. So similar to before, the black mark indicates what usual care was, with the blue squares indicating subsequent quarters during this transition phase. For both of these fidelity metrics, you can see that we're bumped up, but we haven't yet met our fidelity targets, so we're going to keep at it. During what we call the high intensity training phase, you can see that there was a meaningful jump in those fidelity metrics. And this kind of differentiation between usual care, transition, and the HIT phase made us confident enough to investigate outcomes and whether the change in practice that was observed in each of these 3 phases may have affected the gains that the patients were able to get in their physical function. So when we look at both the 10-meter and 6-minute walk test, you can see that there were significant differences between the HIT phase and both usual care and transition, with no differences between usual care and transition. So again, even though we saw meaningful changes in the practice that was actually occurring between usual care and transition, those practice changes were not sufficient to affect these walking outcomes. Furthermore, we looked at the Berg, where there were no differences between the 3 phases in the gains in this measure. While it would be great if we saw greater gains in the HIT phase, it's important to keep in mind that we intentionally practice static balance tasks less. So really thinking about this as, despite practicing those static balance tasks less, there was no detriment in this aspect of the individual's function. Somewhat similar but different for bed-to-chair transfers, as assessed by the FIM here. Even though they were also theoretically practiced less in the HIT phase, we actually saw significantly greater gains in the HIT phase when compared to either usual care or transition phases. We also tracked adverse events, in particular the significant adverse events you can see here, and falls, both with and without injuries. No significant differences between the 3 phases in any of these adverse events. We didn't plan to end our project at month 39. However, there was a COVID pandemic that disrupted all research activities, so we had to stop the project there. So the point of this presentation is really to focus on the sustainability of the practice change. So 1.5 years after COVID disrupted the project, we reinitiated putting the stepwatches on the patients to just look at how sustainable that practice change was. And I'll talk a little bit more about what that actually means for us. So we hypothesized that the fidelity and outcome measure gains that we saw in the HIT phase would be significantly different during the sustainability phase. And the reason that we hypothesized that our practice change would not be sustained was that there was a recent systematic review of knowledge translation projects across all of healthcare that found that less than 50% were sustained, where the vast majority of those keep the different knowledge translation strategies that they initially used in place. Whereas here, as I'll talk about in a second, we took them all away. So inclusion criteria for this study were all individuals admitted to the rehab hospital in Indiana less than 60 days following stroke, and they had to be age 18 to 89. We excluded individuals that were unable to ambulate a short distance prior to the most recent stroke. We also excluded individuals that had no capacity to participate in walking training. So if you had any kind of weight-bearing restrictions, or if you had a lower extremity amputation without a prosthesis. Finally, we excluded individuals that were admitted and then discharged less than a week afterwards, specifically to their home, because the idea was that they weren't necessarily an appropriate candidate for inpatient rehab in the first place. If an individual had a relatively short length of stay but went back to, say, acute care, those individuals' data were still included. During the sustainability phase, we reinitiated the stepwatch throughout the therapy day, including during physical therapy. Hospital staff still had access to the recorded lectures, but no in-person training was provided. We didn't provide any audit and feedback, which seems to be valuable during the implementation part of the project. And we didn't do any direct mentoring from the research staff. We extracted stepping activity both during and outside of therapy, demographic and comorbidity information from the medical record, outcome measures, so still the 10 meter and 6 minute. Again, physical assistance was provided as needed during this assessment according to a FIM type score from total assist all the way through contact guard and better. Specifically focused on the 6 minute walk test, but level of assistance very similar between 10 meter and 6 minute, and then the Berg balance scale. You may notice that transfers are not listed here. That was because the facility transitioned from the FIM to the CARE tool, so we weren't actually able to compare between the phases. Treatment sessions were additionally audited for key aspects related to the fidelity of the intervention. One, whether or not walking was practiced during the session at all, so even if a single step was taken. Was walking prioritized? I talked about this before, but was walking practice the focus of the session as able? Did the therapist document intensity? That could be heart rate or RPE. And whether or not the target intensity was achieved. So for individuals that were cleared for high intensity training, that would be achieving at least 75% of age predicted max, with no requirement on the duration of achieving it, just whether or not they achieved it, or an RPE of at least 15 out of 20 or hard on the Borg scale. We analyzed our data according to 3 different questions. 1, were patients different at admission? 2, were the HIT fidelity metrics different? And 3, were the outcome measure changes different between the phases? Continuous data were not normally distributed, so we used Mann-Whitney U tests, and nominal data were analyzed using chi-squared with alpha set to 0.05. Demographic results are here. You can see that for the most part, participants were similar between the phases. So you had 208 individuals in the HIT phase and 249 individuals in the sustainability phase. We did see that they differed in a few of the demographic attributes. 1, individuals in the sustainability phase were a few years younger at admission. They also were less likely to be on beta blockers, and they were 3 days later post-stroke at admission. In terms of functional abilities at admission, there was no difference between the 2 phases. However, in terms of training characteristics, length of stay was significantly reduced in the sustainability phase, so reduced by 3 days. That was associated with a reduction in the number of therapy sessions, and there was also a reduction in the number of units of therapy per day. In terms of stepping activity, there was no difference in the number of steps per day or steps per hour between the 2 phases. The number of minutes of stepping per hour of therapy, also not different. There was, however, a significant reduction in the stepping rate during therapy. In terms of our chart audits, there was an increase in both of our walking fidelity metrics, so gait practiced and gait prioritized both actually increased in the sustainability phase. Conversely, with our intensity metrics, we saw a significant reduction in both the incidence of intensity documentation and the incidence of achieving the target intensity. Moving on to our outcomes for the 10 meter walk test, Berg, and 6 minute walk test level of assistance, there was no difference between the phases. There was, however, a significant reduction in the 6 minute walk test during the sustainability phase. So in summary, we collected 12 months of sustainability data a year and a half after high intensity training implementation. We found that during the sustainability phase, there was an increased focus on gait activities, but these gait activities were performed at a reduced stepping rate, which likely contributed to the fact that there was no change in the amount of stepping practice provided. Both intensity fidelity metrics were reduced during the sustainability phase, which matches with the reduction in the stepping rate. So likely individuals ambulating at a higher rate are probably going to be doing so at a higher intensity. And these changes were associated with a reduction in the 6-minute walk test gains during the sustainability phase, leading us to conclude that sustaining the amount but not intensity of practice was not sufficient to maintain the gains in outcomes. Subsequent plans for these data are to perform more rigorous statistical analyses to account for baseline differences in the demographic variables, and investigating the discrepancy or the potential discrepancy in heart rate documentation. So attempting to understand whether using the fidelity metric of heart rate documentation is an appropriate representation of whether or not heart rate was actually monitored. I'd like to thank our funding sources and collaborators, and hope you found this talk helpful.